So it's 7 p.m. Japan time. Shall we start our webinar? Good evening to every neurosurgeons around the world, and welcome to the ACNS YNS webinars. Today, our chair is Professor Kimura, who is Associate Professor of the Department of Neurosurgery in Kobe University Graduate School of Medicine in Kobe, Japan. We have two speakers today. The first speaker is Professor Jinghui, who is the Chief Physician of Neurosurgery, the first affiliated hospital of Ningbo University in China, and he specialized in the bypass surgery and has quite a number of publications concerning the bypass surgery. He's also one of the members who were recommended by Professor Xubin, and he's a very active young neurosurgeon in the field of bypass surgery in China. And our second speaker is Dr. James Kiuluku, who is the consultant neurosurgeon of Department of Surgery at the Makueni County Referral Hospitals in Kenya. He's also a previous fellow of the Fujita Health University Benton Hospitals. The first speaker, Professor Lin Jinghui, will talk about the single-stage aneurysm keeping and revascularization for Moyamoya disease with ruptured aneurysm, a key series. While Dr. James will talk about the microsurgical techniques in keeping ophthalmic artery aneurysms. For our discussion today, we have Professor Lisan, who is a professor and the chief of the Neurosurgical Center, Clinical Hospital Fiumfani, and the president of Ukrainian Association of Neurosurgeons. He's also the associate professor of Department of Neurosurgery at the Point Lession Healthcare University. Our second discussion is Dr. Petra, who is assistant professor of the neurosurgery of the Universitas Peliti Harapan Siloam in the hospitals of the Lipo village in Indonesia. To moderate the section with me, we have Joey Sam, Biswa, and Hui Fem. So without further delay, before I hand over the podium to our chair, Professor Kimura, shall I invite Professor Kato to give an introduction?
Thank you, Professor Dr. Ben. It's a kind introduction for us. So yes, please start your Professor Lin. Please start your presentation after you are ready. You're ready. Thank you.
First, I would like to thank the organizer for the kind invitation. Today, I will present our experience with single-stage aneurysm clipping or resection combined with STA-MCA bypass for ruptured aneurysm associated with Moyamoya disease. Intracranial aneurysms occur in about 3% to 15% of patients with Moyamoya disease. They may arise from major artery, deeper perforators, cloacal arteries, or fragile Moyamoya collaterals because some hemorrhagic events are aneurysms related, identifying defined corporate lesion is important rather than attributing every hemorrhage to non-specific collateral rupture. This distinction directly affects whether the patients require aneurysm-directed treatment in addition to management of Moyamoya disease. The mechanism is still unclear. ICA stenosis redirect blood into collateral pathways. Those small fragile vessels then carry more flow, and long-term stress may cause aneurysm formation or rupture. Therefore, earlier revascularization may relieve the pressure on fragile collateral vessels, reduce the occurrence of aneurysms, and the risk of intracranial hemorrhage. In previous review of 131 aneurysms, 56 were located around the circle of Williams, 22% on collateral vessels, and 18 in the basal ganglia, and 4% elsewhere. There was this broad distribution matter because accessible present vessels function, endovascular feasibility, and the risk of collateral injury differ greatly by location. Location is therefore one of the main determinations of treatment selection. Treatment to the aneurysm is mainly endovascular or microsurgical. Endovascular therapy is less invasive and useful for some deep lesions, but small tortuous or fragile vessels may limit access. Microsurgery offer direct visualization, definitive control, and possible hematoma evacuation, but cramping, resection, or parent vessel sacrifice may compromise important collateral flow in secreted patients. This ischemic risk creates a rationale for adding revascularization. Current guidelines support revascularization in selected patients with hemorrhagic Moyamoya disease. However, there do not clear definite how to manage concomitant ruptured aneurysm. Where it requires direct treatment, which modality should be chosen, or when revascularization should be performed. This leaves an important political gap, especially when the aneurysm and bypass might be addressed through the same operation corridor. We received 125 punished patients, and 79 received endovascular treatment. 26 received direct microsurgery, and 20 had no direct aneurysm treatment. Revascularization was performed in 24%. We also reviewed rebreeding 14 patients rebred, and all events occurred before definitive aneurysm obliteration. This supports earlier control of the corporate lesion wherever possible. Those patients face two simultaneous risk: recurrent hemorrhage from an unsecured aneurysm and cerebral ischemia if aneurysm treatment interrupts perfusion relevant collateral vessel. Our question was whether selected patients could undergo definitive aneurysm treatment and immediate flow augmentation during the same operation. The goal was not to recommend a one-stage surgery for every patient, but to define the circumstance in which it may be reasonable. From 2019 to June 2026, our center treated 546 patients with Moyamoya disease, including 176 hemorrhagic cases and 30 patient with ruptured associated aneurysm, 16 undergoing one-stage hematoma evacuation, crimping, and STA-MCA bypass. So the institutional data provide the clinical basis for evaluating the one-stage strategy. This is the first case. Case 1 was admitted which sudden headache. Imaging show a ruptured left MCA region aneurysm with a left frontal hematoma. And CTA showed the frontal hematoma, ventricular dilation, focal MCA stenosis, and the DSA shows the focal MCA stenosis and adjacent scalar aneurysm. Considering the identifiable bleeding source and the associated hematoma, we proceed with one-stage hematoma evacuation, aneurysm crimping, and STA MCA bypass. The left frontal hematoma was first evacuated to achieve the decompression and obtain access to the lesion. The co-parent aneurysm was then identified and crimped. After securing the bleeding source, the STA the STA and the MCA, the M3 bypass was performed to provide immediate core flow augmentation because there was no suitable EMS vessel. So we do the M3 vessels deep in the sylvian fissure to use for the anastomosis. This is the post-operative imaging confirmed the hematoma evacuation and plate aneurysm obliteration and bypass patency. Case 2 was a 24-year-old man with right temporal hemorrhage and intraventricular extension. Followed up imaging later showed in the aneurysm lesion in the abnormal collateral circulation. Initial CTA showed the right MCA occlusion, but no aneurysm. After one week later, interval imaging released a new lesion, an aneurysm, which was confirmed by the DSA. Because the aneurysm appeared unstable and was anatomically related to the hematoma, definitive surgical treatment was selected. After split the sylvian fissures, the abnormal Moyamoya collateral vessels were carefully exposed. The aneurysm lesion was identified in the subcortical region of the right temporal lobe. The aneurysm parent artery was temporarily clamped and the lesion was resected for pathology examination. And STA MCA bypass was then completed to provide immediately follow augment. We do the STA, MCA, M4 bypass. Then use the ICG to confirm the patency. Post-operative CT at the DSA confirmed complete aneurysm obliteration and bypass patency. No post-operative reading was observed. Case 3 was a 60-year-old woman with bilateral hemorrhage in 2022, followed by diagnosis of Moyamoya disease and right STA-MCA bypass in 2023. And then in 2026, he developed a new right basal ganglion hemorrhage with intraventricular extension. Angiograph before 2026 bypass showed no intracranial aneurysm. Therefore, the lesion identified during the current admission was not a known untreated aneurysm. It may have developed later or remain occult on the earlier examination. The first bypass has been performed to provide perfusion, not to treat the aneurysm. The current CT showed the basal ganglion hemorrhage and with extensive intraventricular extension and hydrocephalus. Ventricular drainage was performed, but follow-up CT still show a substantial hemorrhage burden. This aroused concern for an active vascular source and prompted detailed angiographic evaluation. In this setting, DSA is necessary. Then we do it. DSA shows schedule aneurysm arising from abnormal collateral circulation. Its location matched the hemorrhage. The previous bypass remain patency, but it not prevent this new rupture. The operative technique was similar to the shown in the previous cases. Although the previous bypass remain patency, the hemisphere still depend on deeper collateral vessels harboring the schedule aneurysm. Because the aneurysm clipping and the resection should compromise the collateral supply. An additional STA and MCA bypass will perform to provide the immediate supplement flow. This is a new bypass in the front lobe. We use another STA as a donor artery. After this, we also use ICG confirmed the patency of the new bypass. Post-operative imaging confirmed the complete aneurysm obliteration and patency of both two bypasses. No residual aneurysm or post-operative rebreathing was found. Our workflow is straightforward. Identifies culprit aneurysm with CTA or DSA, directly secures lesion and add STM-CA bypass when cerebral perfusion was vulnerable. Verify follow with intraoperative ICG and confirms the result with the post-operative vascular imaging. The principle is to control the hemorrhage while preserving perfusion. Patient selection depends on surgical accessibility, accepted collateral sacrifice, and hemodynamic status of the affected hemisphere. One stage procedure offers four potential evidence. First, immediate aneurysm control and immediately cortical flow augmentation, protection when aneurysm treatment strengthens an important collateral or parent vessel, and avoidance of sunken craniotomy. Previously reported often staged revascularization 1 to 3 months after the hemorrhage. Our approach may reduce the interval risk, but it should be reserved for carefully selected patients. Endovascular treatment and staged surgery remains appropriate alternatives when anatomy or clinical condition favors those approaches. In summary, single-stage aneurysm treatment and STM-CA bypass are technically feasible in selected patients, and second, the definitive treatment of culprit aneurysm is essential to control the immediate bleeding risk, while earlier revascularization may reduce hemodynamic stress on fragile compensatory vessel and thereby lowers the risk of recurrent hemorrhage. And last, the timing and sequence should be individualized according to the aneurysm anatomy and collateral depends and cerebral perfusion. Our principle is to secure the culprit aneurysm earlier and add revascularization when the hemisphere remains hemodynamically vulnerable. This stage should be viewed as an individualized option rather than a universal solution. Okay, thank you very much for your attention.
Kimura Sensei, please unmute yourself.
Thank you. Sorry. Thank you, Professor Lin. Thank you for your fantastic surgical cases. Excellent treated. So maybe even in a difficult condition, suffering the intracranial hemorrhage due to the ruptured aneurysm caused from the Moyamoya disease. And so maybe treated difficult situation. So some patients suffer the rebleeding and initially could not find out the aneurysm, but rebleeding cases, you can find a new de novo aneurysm caused to the rebleeding. So a fantastic successful treatment case. I was so surprised, impressed your cases. I learned a lot. Thank you so much. So I have several questions for you. So can you, okay? So what is the difference between the pathological differences between the normal so-called circular aneurysm and the aneurysm caused from the Moyamoya cases? I think thin-walled aneurysm, maybe fragile aneurysm were formed in the in the hematoma. How about the intraoperative finding of the Moyamoya case, Moyamoya specific aneurysm? Thank you. Can you hear me?
Ben,
Maybe I'll just translate a bit. So, 林教授他 Kimura 先生问的是他烟幕病的这个血管瘤跟这个普通的血管瘤的病理有没有分别？是不是特别的脆弱？你手术中间有什么发现？
那你帮我翻译一下好了啊，就是这个它只是颈内动脉的主干可能是完整的，但是到了末端以后，后面的血管全部都是畸形的、脆弱的血管，血管都是萎缩的，然后血管壁非常的细，没有明显的大脑中动脉系统，而且非常的脆弱。
So, Professor Lin, sorry about Professor Lin, sorry about the need of the translation, but he just replied. So after the bifurcation, the carotid bifurcations, so the T junction, so when in the Moyamoya disease, the vessels will will both the MCA and the ACA will become very attractive, and then so they will become small, and the vessel wall will become more fragile. And also it happens also on the aneurysm. So it will be, the vessel wall is relatively fragile for those more and more associated aneurysms. But the dissection itself, and then because in acute stage, so it will be mixed with the cord. So it's relatively okay to say, and also the blood flow and the pressure of that aneurysm might not be that high because the blood supply was already jeopardized by the Moyamoya disease.
Yes.
Thank you.
Yes.
Okay. So maybe in the last case, maybe you approach to the hematoma directly to obliterate the aneurysm. So how to avoid the intraoperative rupture? So by just approach to the by your hematomic cavity to the aneurysm. Maybe in the intraoperative in evacuating the hematoma, you may encounter the intraoperative rupture directly because you did not approach to the parent artery first. If you approach to the hematomic cavity, how do you manage their intraoperative rupture? Thank you.
林教授就是怎么样防止你直接从这个血块里面就把这个血管瘤拿出来，就是你怎么样防止它是输中的破裂，因为你直接除血管，你没有就是近端的夹壁。
那我一般会去从造影的先去仔细去看一下这个血管的造影，然后我大概可以就是这个只能大概猜测它是从哪个方向的，这个载流血管从哪个方向过来，我会先从这个方向去做一些解剖和分离，然后它大部分的血管其实主干都是从这个侧裂过来的，就是在颈内动脉的末端。这个一般都是这个是它的一个主要的一个载流血管和血流的一个血管的一个起始部，所以我会先打开侧裂，暴露这个颈内动脉和这些烟雾血管的一些起始部，这样再去做这个清除血肿。这样的话，一旦破裂， 我的近端控制就会比较好，这是一个问
So
题。第二个，
Professor,
它这个血流其实不像是这种大动脉的动脉流，这么难以控制，就一旦出血，它其实也是相对还是好控制的。
for Professor Kimura, Professor Lin said, so there are 2 points. The first point is important to first to do the Sylvian dissection first before you attempt the hematoma to find the MCA supply and also possibly to get the more vessel supplies based on the angio. And then of course, and then before attempting to go into the aneurysms or go into hematoma, you try to see if you get the supplying more vessel. But usually, this supplying more vessel may be small. So we'll try to see if these vessels can be dissected. If not, and then you first excise the aneurysm, and then of course the another consideration is to do the SAMC bypass to perfuse the supplying blink for these small vessels. And the second point is that because the pressure of this type of the vessels is usually relatively lower, I would say compared to the normal, like what we have for the MC aneurysm for the normal patients with normal disease, because the vessel is not stenotic. So it's relatively easier to control the hemorrhage if it happens.
Totally agree. Thank you. I totally agree with your comment. But maybe it causes rebleeding in this situation. So maybe easy to rupture intraoperatively, I thought. So that's why I asked you a question. So yeah, thank you. Thank you. I enjoyed a lot. Thank you. So any other question from Dr. Biswas? Could you please your question? Thank you.
Thank you, Sensei, for the opportunity. It's a very excellent presentation. Sensei, there development of the aneurysms associated with Moyamoya, both in the anterior circulation and sometimes in the posterior circulation. I just want to know what would be the treatment modality in case of posterior circulation, which has ruptured, and in case of anterior circulation, which is also ruptured.
后循环跟前循环有没有分别？
你是什么？
后循环跟前循环的这个血管瘤有没有处理手法有没有分别？
这个处理就是我倾向于，如果是有很大的血肿要清除，这个开颅是必不可少的，然后同时夹杂着动脉瘤跟一个血管的重建。如果后循环动脉瘤很多是没有形成血肿的，这样的话去开颅可能就是这个收益并不是很大。这样的话，我们可能先选择介入治疗。
So yeah, Biswa. So Professor Lin said that in case of sizable hematoma in posterior circulation, he will still go for the open clipping, and then but if not, if there is no sizable hematoma, he might offer the endovascular treatment.
Since it's just a subsequent question, if you allow, was there any perioperative or immediate postoperative complications after surgical intervention? I mean, if we compare with the endovascular treatment, was there any comparative findings in terms of complications after surgery or after intervention?
Biswa, your question is after the.
I mean, if we do surgery, microsurgery or endovascular treatment for aneurysm in Moyamoya, is there any comparative findings in terms of complication, post-treatment complications?
就是在烟幕病跟普通的血管病变的血管瘤里面，就是如果做介入跟开颅，它的手术风险有没有分别？
我觉得这个根据医生的一个擅长来决定的。 这是一个。第二个就是如果我个人认为最大的差别就是一旦在手术中如果破裂了，那么开颅的话，它的控制的成功率应该是要高于介入治疗的，因为你已经暴露动脉瘤，或者你已经或者说已经实现了近端控制，这种情况下，动脉瘤一旦破裂，相对也是比这个介入要好控制。而
Yeah,
且
this
介入
was
很多可能放支架的话，它可能用了抗凝药物，这样的话一旦出血，它的风险会更大，这是我的体会。
so yeah, this was just sorry for waiting. So there are a few points. The first point is around about the expertise of the surgeons. And it depends on how comfortable you are for the treatment, either in vascular or open. But and the second point is that in acute state, in rupture state, we will try to avoid using the stent or flow director to avoid the antiplatelet in the centers. So in terms of like complications, in the whether it's Moyamoya or low molar aneurysm, I think this highly depend on the expertise, and we did not have too much data on that.
Okay. Thank you, Sensei. Thank you.
Good question.
Professor, our discussion, Professor Odistan and Petra, any comments?
No.
Hello, Ben.
Petra, please. Yeah.
Yes, Professor Kimura. So, Dr. Lin, thank you so much for your presentation. I'm surprised when I reread the literature, it's actually high incidence. There's something like 15 to 20% of aneurysm in Moyamoya. So I think it's a very important topic. I want to ask about your surgical technique. I was looking at your second case, and I'm thinking because you already planning for revascularization, you already planning for bypass, does this actually expand your technique? Like if an aneurysm is a little bit too difficult, you can directly plan for trapping or directly plan for some vessel sacrifice because you're already preparing for a microvascular. What do you think, Professor?
就是如果血管瘤你要夹壁的话，会直接先把这个血管夹壁了以后，做了这个封闭以后，就是避免这个血管瘤再出血，先搭桥，还会再把这个血管瘤切掉，有可能会这样吗？
一般是先处理动脉瘤，我们的考虑是这样一个，可能会去先清血肿，减轻这个颅内的压力。但是如果颅内压力减轻以后，有可能血管瘤就容易破裂出血。这样的话，如果你在搭桥的过程中出现了这个动脉瘤破裂，或者你血管缝到一半，出现了这个动脉瘤的破裂，那这个再去处理动脉瘤以后，然后返回来再去继续做搭桥，那么这个中间这个阻断时间就会非常的长，是吧？第二个考虑的是，如果你血管压力很高，你这个受体血管它就是被一个牵拉的一个扭曲的一个状态，这样的也会影响你做一个 bypass。主要是这两点考虑的。而且我觉得动脉瘤肯定是越早处理越好，因为它是一个潜在的风险，随时有可能破裂。
So I think there are a few points to your questions, Petra. So I think the first is to avoid they will try to secure the aneurysms and to see if the bypass, whether the bypass is necessary. And yes, it's possible to do the bypass at the same stage but the main focus is to aim for the shortest clamp time. And another point is try to secure the aneurysm, because if you put a clip there, it might add additional tearing stress to the vessel that you want to bypass. So yeah, there's the principles.
Thank you.
Thank you.
Good question.
Any other question?
No.
So, Dr. Ben, I have one more question now. So,
Yes.
if the patient have the no intraparenchymal hemorrhage, just a intraventricular hemorrhage, suffered intraventricular hemorrhage due to the periventricular anastomosis formed aneurysm. So, in such a situation, maybe difficult to approach to the aneurysm itself to obliterate aneurysm. So maybe in some case, in such a case, maybe in the first case, just perform the STMC bypass. The following, just observe post-operatively, the aneurysm will disappear in the course to, yes, maybe in some cases, very difficult, very dangerous case to approach to the aneurysm to avoid additionally secondary injury to, yes. So in such situation, maybe STMCA, just perform the STMCA may be justified to avoid a complication. How about this case? Thank you.
It's very
Just
very good
something.
question. This is a very good question. 它有一个很好的问题，就是如果你是一种房室的出血，就是在 ventricle 里面的出血，就是它有一些叶幕病的很小的，在房室附近的小的血管瘤破裂了，可不可以？你会怎么样处理？会只做一个 SAMC 搭桥走之后等它的复诊，看哪个血管瘤会不会消失掉，还是怎么样处理？因为它如果可能直接去就是很深部的血管瘤也很小，就是有风险。
有没有出血？有没有大的血肿？
有的，但是在房室里边。
我是这么认为的，如果有一个大的血肿，然后这个血肿，这个动脉瘤在血肿腔里面，这样的话，我们这个手术清除血肿以后，去夹闭这个动脉瘤，其实没有造成额外的损伤。但是如果没有大的血肿，只是一个蛛网膜下腔出血，或者一个很小的一个血肿在深部，这样我个人是不建议去做一个夹闭对，这样去做一个夹闭
就是如果房室里边出血，房室里边，
如果单纯是脑室里面出血，
嗯
这样我是不建议去做这样一个手术的，就是一站式的这个血肿清除加这个动脉瘤夹闭和这个搭桥，
你会先做
所以这个
搭桥吗？
就对那要等那个这个血清除完全以后，过一段时间1到3个月再去做搭桥，搭完桥以后，有可能这个动脉瘤它自己会萎缩的，如果没有萎缩，再去考虑下一步的一个处理。
Yeah,
因为就是
Professor.
说，就是如果没有一个血肿
Yeah,
帮
okay.
助一个大的
Professor
血肿，
Kimura, so
就是可以帮助
Professor Lee
给一个通道。
said that in case of the intraventricular hemorrhage, pure intraventricular, he with the small aneurysm that you mentioned, in this situation to try to avoid the single stage surgery. So we'll probably to wait the resolution of the intraventricular hemorrhage and to have a reassessment angio in 1 to 3 months. And then they might consider a only STMC bypass because this aneurysm may subside after the bypass.
Thank you. Thank you for your comment. So, thank you. And additionally, Professor Brozniak, do you have some comment? Alexander, thank you.
Yes, thank you, Professor Kimura.
Thank you.
Professor Lin, thank you for great presentation. It's really unfortunately, maybe fortunately, in my country we do not have so many cases with the Moyamoya. It's very only sporadic cases in some departments. So I will speak from some point of view of methodology. Really very brave step, very brave surgery and excellent surgery, and my congratulations, really great. But you know, in stroke guidelines, they are based on the very weak evidence recommendation, on the very weak. But anyway, to recommend that method, to let it be used the other neurosurgeons, I'd advise you to show the clinical condition of the patient before and after and follow up. At least modified Rankin scale would be enough to say before surgery, after surgery, and half year for after surgery. In this case, you can recommend, and your method you propose will be more compatible and might be recommended for other clinicians, because you showed excellent clinic, but to recommend it to clinical implementation, you must improve it with the real neurological condition of the patient before, after. This is my recommendation, but in general, really great surgery and micromodulation. Thank you. Thank you.
Yeah, thank you.
Thank you.
Nice comment. Thank you. I totally agree with the comment. Yeah, we want to know the patient condition. Yeah, post-op. Yes, thank you.
Yes.
Yes.
Okay, and Dr. Sam, do you have some comment? Thank you.
Not really. Very interesting. I've never encountered Moyamoya with an aneurysm before. So yeah, thank you for the great lecture. Yeah.
Thank you. Any other comment, question?
And I think for the time, we can move to
Okay.
our next speaker.
Okay. Thank you again, Professor Lee. So fantastic cases. I agree with your strategy. One-stage surgery for the Moyamoya case, ruptured aneurysm, STMC bypass with a total obliteration of the aneurysm. Thank you for sharing your experiences. Nice sharing. Nice experiences. Thank you. See you next time. Thank you. Okay, I just want to move to the next speaker, Dr. James. He will talk about the microsurgical techniques in clipping of an ophthalmic artery aneurysm. Please start your presentation when you are ready. Thank you.
Hey, hello everyone. I hope my slides are visible.
Yeah, now it's visible.
Yeah.
Can
So
you
my
click
name is
to the presentation? Yes.
my name is Dr. James Kiuluku. I work in Kenya. I work at the neurosurgical department of Makueni County Referral Hospital. I'm a fellow of the Eastern African College of Surgeons, and also I'm a fellow of Bantania Hospital. I'm going to try and squeeze this presentation in. Credit to the previous speaker, amazing presentation. So I'll just talk about ophthalmic artery aneurysms and some of the techniques we use for treatment. As a matter of principle, in terms of aneurysmal formation, the new frontiers are in genetics. I'll just highlight two genes that are very important. SOC17, which is an endothelial gene that helps with endothelial repair. And downregulation of this gene usually tends to cause a breakdown of the endothelium, exposing the basement membrane to inflammatory processes. Endothelin-1 usually has two receptors, B and A. A is on the vascular smooth muscle, mediating for vasoconstriction through calcium, while B is on the endothelium itself, mediating vasodilation through nitric oxide. These two are basically two sides of the same coin. It's a balance of vascular tone, and therefore dysregulation here will cause aneurysmal expansion. For ophthalmic artery aneurysms, they consist about 2 to 5% of all intracranial aneurysms occurring at the junction of the ICA and the ophthalmic artery orifice. They tend to grow dorsomedially towards the lateral edge of the optic nerve. They can also occur on the medial aspect. However, these are much more rare. We can have this discussion today because anatomically they are located in a complex region in the skull base, and therefore treatment is challenging. Due to this projection of the aneurysm, some visual signs are quite predictable. So as the aneurysm enlarges, it impinges on the lateral portion of the optic nerve, compressing the inferior temporal fibers, and this will cause an ipsilateral monocular superior nasal quadrantianopsia. This aneurysm continues to become bigger, and it ends up compressing displacing the nerve onto the falciform ligament, and this will cause compression of the superior temporal fibers. This will end up causing a monoocular inferior nasal quadrantianopsia. As the aneurysm grows bigger to involve the whole nerve and the knee of Willebrand, you end up getting a junctional scotoma, which is monoocular blindness on the ipsilateral side. Contralateral side, you're going to get a pie in the sky kind of deficit. And therefore, the two landmark studies in terms of aneurysm management, I'll start with the ISUA study, which basically gave us a natural history. And for this paraclinoidal ICA aneurysm, 5-year cumulative rupture risk was found to be 2.5% for aneurysms that are 7 to 12 millimeters. For below 7, rupture risk was almost 0, above 12, 14.5. The ISAT study has basically entrenched endovascular treatment in our practices. They were basically able to prove that endovascular treatment has less morbidity. The rebleed chances are what were in favor of the surgical arm, and that's the kind of saving grace for microsurgical treatment. And therefore, when it comes to a comparative study for ophthalmic artery aneurysms themselves, I was able to find this systematic review. This is mainly American data. It was done in 2024, and they were able to find 9 articles covering about 900 ophthalmic artery aneurysms, and they did not find any significant difference in clinical outcomes in their series. And therefore, I'll finish with this. In my literature, I look at this study, which forms the basis of why I chose this topic today. The ACGME, which is the American Council of Graduate Medical Education, conducted a study in 2018. And this study was basically to check logs of their neurosurgical residents. And they did a retrospective study of about 8 years, from 2009 to 2017. They were able to notice that there were increased case logs for their residents. However, there was an inverse relationship between open vascular and endovascular procedures. And they noted that there was a decrease in open vascular procedures being logged and an increase in endovascular procedures. And what this really shows is that as young surgeons graduating right now, we are less and less exposed to microsurgical techniques. And therefore, I present to you a case, a 65-year-old female treated at Bantane Hospital under Professor Kato and Dr. Tanaka. This was a patient who came in with an unruptured ICA aneurysm. Diagnosed in 2017, underwent follow-up for about 10 years. And around 2026, they requested to have surgical treatment done. The only positive history was some tension headaches, but abnormality, brain MRI was not significant. The patient was hypertensive, good BP control, labs were all right. We made this diagnosis of an unruptured right ICA aneurysm, and we planned for craniotomy and microsurgical approach. Pterional approach was planned for. Basically, the main workhorse for anterior circulation aneurysms, and the craniotomy. We placed the patient was placed supine head 30 degrees, a bit of extension of the neck as well. We prepared the neck just in case we needed vascular control there. Intraoperative neuromonitoring was used, visual evoked potentials were used. This image shows the skin flap. And what I want to highlight here is you have to dissect to the root of the zygoma to be able to get an adequate window. And extradural drilling of the sphenoid ridge is a very important step, gives you a good operating corridor, and this should be taken to the very edge of the superior orbital fissure. Extradural decompression of the optic nerve is one of the major advantages of open surgery. You're able to get early decompression of the optic nerve. The optic nerve, even if there's a bit of manipulation, you've decompressed the bony elements, and this is especially for patients who have visual deficits. Here, this is just an image showing the proximity of the internal carotid. This is part of the anterior clinoid process that we've started to remove. And therefore, you can see adequate decompression of the optic nerve being done there right next to the orbit. The anterior clinoidectomy is basically the most important step of this procedure. Dolenk was able to describe a total extradural approach to the anterior clinoid. He was doing this mainly for approaches to the cavernous sinus. However, it stays true, especially for this segment of the internal carotid. And therefore, you start by unroofing the optic canal, cavitating the anterior clinoid process, removing it and block. And what you remain with is a strut. And the strut has to be removed as well. And here you can see excision of a dural fold right on top of the internal carotid. And therefore, the anterior clinoid basically has two attachments: superior attachment onto the optic canal, inferior attachment onto the optic strut. The optic strut is basically the landmark separating the optic canal and the superior orbital fissure. And therefore, by removing it, you're able to maximize your exposure. It is noted that basically you can, with the removal of the anterior clinoid, you're able to visualize the paraclinoid ICA. It gives you about maybe 9 millimeters extra visualization of the proximal ICA, and this can help even with proximal control in case of rupture, intraoperative rupture. Sylvian fissure dissection was important. Here we did a Sylvian fissure dissection headed down to the subfrontal region. The main element was to be able to observe the intradural ICA, and once that was done, we were able to open the dura and basically open the dura and take it all the way down to the distal dural ring. Here you can see the distal dural ring being opened medially right on top of the internal carotid and towards the optic nerve there. What you see here on this right-sided image is a beautiful picture of the extradural extradural internal carotid and the intradural internal carotid arteries here. The attachment of the distal dural ring is mapped out here. The cranial nerve 2 can be seen above there, and here at this point you have very good exposure. And therefore, when it comes to assessment of the aneurysm, you have to have a pre and post clipping modalities, either intraoperative ICGs or endoscopy, which we were able to perform here. Endoscopy here showing the ophthalmic artery coming off right at the base of the aneurysm. Can see expert clip application here by Professor Kato, and postoperative ICG showed preservation of the ophthalmic artery. This is the post-op angio. You can see preservation of the ophthalmic artery there. So that's the end of my presentation. I just recently finished my training at Bantania Hospital. It was basically one of the best experiences of my life. I have to thank Professor Kato again for giving me this opportunity. These are some of the images we had in Japan and some of the fellows I got to interact with. Thank you.
Thank you, Dr. James. Thank you for your sharing your experiences in staying in Bantam Hospital, and you learned a lot. You learned fantastic experiences during your stay, including your shown presented cases in the surgical case for the paraclinoid aneurysm. Maybe recent nowadays especially in the paracranial aneurysm, isophthalmic aneurysm may be treated mainly by endovascular treatment strategy. Recently, maybe the flow diversion for the FD shifted for the FD cases. So my first question is what kind of aneurysm among the IC ophthalmic aneurysm can be good candidate for the microsurgical treatment case? Do you have some comment?
Yeah, what we are seeing, it's true, I agree with you. Endovascular treatment, especially with the advent of the flow diverter, making this surgery safer. Um, but if you try and stratify who fits in the surgical category, you might look for patients who have a wide neck aneurysms, patients who have ophthalmic artery origin, maybe
Yeah.
so close to the aneurysm or directly from the aneurysm. And these are some of the patients you might consider to do open surgery. Yeah.
Yeah.
Maybe
I
or a patient a large aneurysm that is thrombosed, and maybe you might need physical decompression of the nerve at that point. So, but it is becoming rarer and rarer, and that's why I chose to pick out this case.
Yeah, thank you. I think this case aneurysm originates the ophthalmic artery itself. So in this case, maybe FD even if the FD flow diverter was inserted to carotid artery, but in this case, is aneurysm is originate from the ophthalmic artery itself. So maybe it may be difficult to treat the endovascular approach. So that's why Professor choose for the microsurgical treatment. Yeah, thank you. Okay, do you have another? We have some another question. Please start with Dr. Biswas. Thank you.
Sensei, thank you. Actually, a few questions. First of all, when there is a paracranial aneurysm and the size is less than 4 millimeter, it has been seen that it doesn't actually grow in future in size. But what would be the natural history in case of ophthalmic variety of the paracranial aneurysm? I want to know this, number one. And number two is why didn't you choose a flow diverter for this case? And number three, we have seen that for ACP drilling, nowadays there is a special ronger to take out the ACP rather than drilling it, because drilling carries 2 to 5% chance of optic nerve injury. So these are three basic questions that I want to ask.
Okay, maybe I can try answer first and the last question. The first question, I agree with you. Aneurysm about 4 millimeters, really, they might not grow again. I had put up the slide on the ISUA trial that even in terms of rupture risk, if the aneurysm is less than 7 millimeters, the rupture risk is really low. If you look at the follow-up period for this patient, it was almost 10 years. So I think psychologically, the patients kind of get really frustrated about living with an aneurysm. That's what I would say about that. For the last question, we did not use drilling for the ACP. Yes, the drill will cause thermal. They say you have to constantly irrigate, but you still get risk of thermal injury. But in our case, we did not use drilling. We ronjoed it out and block. For the flow diverter, I think I will I'll leave the Nini to Dr. Kimura or Professor Kato, but we did not use a flow diverter for this case.
So Kimura Sensei, is there any comment regarding why did we choose the microsurgical reconstruction rather than not choosing the endovascular treatment, especially flow diverter? Yeah.
Thank you for your question. So good point you mentioned about it. So important, but at the first, the patient, just the patient has some frustrated, as Dr. James mentioned, has some anxiety having a rupture, scared about the future rupture. Always patient thinking about it. How can I manage this in such a situation to please treat this aneurysm in vascular or microsurgical or not. So. And also, this aneurysm originates from the ophthalmic artery itself. This kind of aneurysm may be treated difficult in treating the endovascular approach. So I think that even in this era, so in this kind of aneurysm can be treated microsurgical clipping may be good candidate for the treatment option. Yeah, I think. Thank you.
Thank you, Sensei. Thank you so much.
Jesus, thank you very much for your question. So right now in Japan, we cannot use the FD. The aneurysm size is over 5 millimeters. Otherwise,
Okay.
Yeah.
That is hemolygation.
Yeah.
Otherwise.
Good.
Thank you, Sensei. Thank you.
Thank you. That's a good point. Important point. Thank you. Dr. Ben, do you have a comment, question?
Yeah.
Thank you.
Yes. The first thing is to congratulate the Fujita team for these good cases. And I think the microsurgery is very important for these paracardial aneurysms. Although now, as mentioned by previous speakers, that the use of the flow director is becoming more and more common. But I think that from the literature that I know of, the long in terms of long-term follow-up, and there will be less chance of the recurrence of the aneurysms and more obliterations of the aneurysm, if I'm correct. And also avoid the use of the antiplatelet. And it's also a point that we might have to consider. Biswa just asked the question that I want to raise about how do you choose between the flow diverter and the open surgery, which case is suitable. But I would like to ask about because Kimura Sensei or Professor Kato, like in Fujita or in Kobe, do you use CFD to guide your treatment? Like which case is good for the flow diverter or which case is good for clipping? Any details on that?
Thank you, Dr. Ben. Good questions for me. In the using the CFD, if it possible, if it would be possible to predict the good option, good candidate for the treatment of the endovascular or microsurgical treatment using the CFD analysis preoperatively. But now it's no definite finding to detect the which good modality is a good or not. I can't say you just using the CFD, but in future, I just want to clarify the good modality, best modality for the treatment of the aneurysm using the CFD. Thank you for your comment. Thank you.
Thank you.
Okay, Dr. Alexander, do you have some comment? Thank you.
A very short comment. My congratulations to Fujita Hospital team. Great surgery, great case, and thank you very much, Dr. Kiuluku, for excellent presentation. Actually, that's all. Nothing to discuss, nothing to comment. Thank you.
Thank you. Thank you.
Petra, any comment?
Yes,
Peter?
hello.
Okay, thank you.
Thank you, Kimura Sensei. So, James, welcome. Very good to see you again. It's been 1.5 years since I last see you.
Yes.
I want to ask James, with your training in Bantane, I think you have a very big caseload, especially for surgical treatment of aneurysm. Do you feel very confident about starting the service in Kenya? And so far, how is your experience? Are there many patients that you can try the anterior surgery?
Hey Petra, I'm doing okay. Since I've been back, I've done definitely the experience at Bantani has really given me confidence. I've done one ACOM, open surgical clipping, but to be honest, the the hospital I work in has a cath lab. So most patients we tend to coil. And what we've realized is like I was trying to explain with the study, ACGME study, we are doing so many coilings to the point where we are losing fine skills of Sylvian Fisher dissection and things like that. So in Kenya, it's a bit both. The guys who don't have cath labs in their facility tend to clip more, and the patients with cath labs tend to do more coiling. So it's a bit of both in our country.
But I think it's a very good experience for you. I mean, now you can see how is the outcome for similar size and location of aneurysm in Kenya. Do you think it's better for coiling or surgery?
It's definitely better for coiling. It's definitely better for coiling, yeah.
Thank you. Later we will improve this on the surgery arm.
I hope.
True.
I hope so.
We all hope to improve the surgical arm.
Yeah.
Yeah.
So James, what is our technical point? Why the natural postoperative growth was worse in the microsurgical case in the paracranial aneurysm? How do you think about it?
So I think as a surgeon, you might be quite skilled. But in terms of our healthcare system, you need development from critical care to anesthesiology to all this that help the surgery to be a success. So I think it's about just training more. Professor Kato has started even a nurse practitioner fellowship. So you just need a good team around you, and I think the outcomes become better.
I see. I hope in near future, it will so. Thank you.
Yeah.
I saw Professor Prasad is here from Afghanistan. Any comments from you? Hello, Professor Prasad.
Hello, Assalamu alaikum. Konnichiwa.
Konnichiwa. Hello.
Hello. Greeting. Thank you very much. Great webinar and excellent presentations and achievement. Congratulations, especially for young neurosurgeons. And we are proud of you. Thank you very much.
Thank you for joining us today. Thank you. Dr. Sam, do you have some comment? Thank you.
Hi, thanks, Prof. Kimura. Hi, James. Great presentation. Thank you for highlighting the special preparations you need for this type of aneurysm. Maybe you would just like to ask on your proximal control. How do you perform it when you open the neck? How do you close up the ICA? Where do you clip, or what clip would you use? Or you use the vessel loop to control the ICA for proximal control? Thanks.
Usually, like in Kenya, for this case, we didn't get to do the proximal control, so I didn't get to see to experience it in Japan. But usually for proximal control in Kenya, we tend to use temporary clips instead of loops. But what I've come to experience is very few times do we perform proximal control. The risk of injuring an atherosclerotic vessel is too high. So usually with good exposure of the aneurysm, usually you just tend to clip it.
Right. Thank you very much. Yeah, sometimes I also try to avoid if possible, because can injure the vessel and sometimes even trigger vasospasm. Yeah, just that in this particular case, it is difficult to put the proximal control without opening the neck, I think.
Important point. Yeah, thank you. Any other comment or question? Dr. Lin, do you have some comment? Professor Lin?
Professor Lin, any comments from you?
Can I ask one question?
Yeah.
I once performed craniotomy for an IC intracranial artery aneurysm located in the oculomotor segment of internal carotid artery. Upon removing the anterior clinoid processes, we discovered a gas cavity. We sealed it with bone wax, and however, after 6 months, the patient still exhibited a gas-filled skull. Are there any method to reduce such complications? Ben, can you understand?
你说什么？那个
就是我磨除前床突，就是我也做过一个眼动脉段的动脉瘤做夹壁，然后我磨除前床突以后，发现有一点气房，然后我用骨蜡封闭以后，就把这个手术做完了。但是6个月以后，这个病人出现了一个气颅，我怀疑是这个骨蜡的封闭可能不是很完善。
Okay. Yeah, so such comment from Professor Lin. So he has one case that previously the patients it's about the lemmatization of anterior canal and how to prevent pneumocephalus. So he has a case that developed delayed pneumocephalus and 6 months after the surgery. But during the surgery, he used the bone wax to seal the air cells. So any special technique to prevent the CSF leak or pneumocephalus? James?
I don't have experience with that, so I'll ask Prof. Kimura and maybe Prof. Kato to speak on it.
Oh, yeah. Usually I use a muscle plug or a fascia or something. Recently, we can use a Duragen for the close the pneumatized air cell. But usually very easy to use, harvest the piece of the muscle was pressed into the pneumatized air cell intraoperatively, maybe sufficient. Of course, fibrin group is additionally used. Thank you. How about the Professor Kato? Thank you.
It is the same.
Thank you.
As Kimura-sensei said.
Same. For me, I would also use the temporaris and then which soak in the betadine to push into the pneumatized cell, and then use the maybe some artificial dura to cover with some tissue glue.
Thank you. But important point. Yeah, postoperative avoidance, the CSF leakage is a very important point for the patient. Yeah, thank you. Thank you. Good question. Thank you. Is there any question?
If there's no more question, shall I invite Professor Kato to give some concluding remarks for this webinar?
So two talks were excellent. Congratulations, especially Dr. Lin. He is a very skillful neurosurgeon, I think. Because Moyamoya, also in Japan, we have so many Moyamoya. But quite difficult to treat endovascular for the occlusive of the aneurysm because of that. Moyamoya is starts from the IC terminal. So that means catheter cannot go enter that part, I think. That's why is rupture one and a rather bigger one. I think direct clipping is much better, I think. But many vessels is very fragile. I think simultaneously the bypass and also the clipping is very, very tough and a difficult task, I think. So, conversation. And also, James, nice to see you again. We are so happy to hear your lecture this time. So I think in Japan is 100% the endovascular treatment is done by neurosurgeon. But I think another country, some country are also treated by the radiologist. So as chief of the department, so we need to advance, of course, the surgical skill, but also the improvement of the endovascular the treatment. So recently we used so many web. The web device is getting smaller and smaller. That means the 4 millimeter is enough for the smaller the web. So we can give them the chance to consider how improve their skill because they have considered many overcome of the difficulty of the treatment of the endovascular. I think so. In the future, maybe there's an open surgery everywhere in the world. I think so. That means is endovascular task or endovascular technique should be improved in the future. So the FD and also the web. We don't need anticoagulant after the treatment. So that is a good advantage for the patient. So I think so each case we need to learn so many things. But I think James he picked up a very difficult case because I see ophthalmic artery is quite difficult. Sometimes we considering which is better treated by endovascular or open surgery or observation. So that means is CFD is quite good. The CFD is Kimura is expert. So our staff is always have some doubts. Ask Kimura sensei all the time.
Thank you.
So he helped us a lot. So, but still unknown. Not yet good answer from the CFD.
Yeah.
But anyway, I think the two talks were wonderful. Thank you very much.
Okay, Ben, I have a 1 point lesson lecture. Sorry.
Yes.
So.
Yeah, please, Kimura.
Briefly.
Sensei.
Yeah. Sorry. Yeah, just prepared. But I can show you next time. But I just briefly.
No, it's okay. It's okay.
No, it's okay. It's okay. Please,
Yes,
please. Okay. Okay. Can you see this slide?
Yes.
Thank you for your giving a great chance to talk about the briefly short comment for the technical issue for the Moyamoya disease using the bypass surgery in the bypass surgery. And as a doctor, Professor Lin also mentioned, in the Moyamoya disease is characterized by the stenosis or occlusion centered on the terminal of the intracranial ICA. And this Moyamoya vessel, CT angiography and Moya MRI demonstrated abnormal vascular networks. Its shape is like a hazy and a puff of smoke appearance. It's called, in Japanese term, is Moyamoya. So it's the disease is called Moyamoya disease, is a Japanese name. And for treatment of Moyamoya disease, as you know, usually we do the combined surgery, direct revascularization, and also the indirect revascularization. We do the combined strategy in the patient using the direct revascularization and also indirect revascularization. In the direct revascularization, we perform the STA, MCA anastomosis. A single barrel or double barrel, we can choose for the patient condition. And in direct revascularization, we do the EDMAPs, so-called EDMAPs, encephalodural, myo-arterial, pericranial synostosis. You can see that this is STMC anastomosis. How to perform the accurate and accurate STMC anastomosis is important issue to perform the safe surgery. The golden rule is I have three golden rule included in this surgery. The first is keep the recipient artery occlusion time as short as possible. Usually, we need to complete this anastomosis within the 30 minutes. Preferably less than 20 minutes is preferable. I think, but in less than 30 minutes is sufficient for the safe surgery. The second is never grasp the intima directly with forceps. Never grasp the intima. The third is create adequate intimal eversion, like this, for the precise intima to intima opposition. To shaping this anastomosis shape is important for to avoid the avoid occlusion, thrombus formation around this area. If you insert, I will mention later, if you insert the needle so far away from the cut edge, the adventitia come into the lumen. So here the platelet aggregation occurs postoperatively immediately after the operation. So the acute occlusion, acute graft occlusion may occur. To avoid this kind of configuration to perform the safe surgery. Yes, I just want to mention about the surgical steps in the STMC double barrel anastomosis with a combined EDAS, EDMAPS, encephaloduodenal synangiosis. First, you need to make this is the two ST branch, frontal branch and the parietal branch, and traced on the patient surface, patient scalp. And the skin incision was made like a curvilinear skin incision. So just here, just above the parietal branch of the STA. And the two STA branch was harvested and reflected inferiorly initially. And relatively large craniotomy. And after that, the two barrel anastomosis was performed to the M4 portion. And the temporal muscle and the pericranium, and also the fascia was covered over the brain as indirect revascularization. So this patient is a little boy, less than 10 years, suffering the transient right hemiparesis once a month for the past couple of years. The DSA demonstrated the Moyamoya disease in the terminal ICA was stenotic, and the Suzuki stage 3 Moyamoya disease. And this patient positioned the spine under general anesthesia. The head was fixed with a Mayfield clamp. And under the microsurgical inspection, the ST was harvested, two ST was harvested. And the frontal branch of ST was harvested under scalp, under the reflected skin flap. And the two ST was harvested about 6 or 7 centimeter. The heparinized saline solution were injected to avoid the intraoperative occlusion of the both graft of STA. And the temporal fascia was harvested based on the posterior side. And the temporal muscle was divided into 2 layers for the indirect anastomosis revascularization. The frontal pericranial was also harvested. The frontal a door was opened and inside. Can you hear me?
Yes.
Yes, yes.
Okay. And a small perforator was sacrificed, and the rubber seat was inserted under the recipient artery. This is the temporal recipient artery. After that, they're creating the donor artery, and the loose connective tissue was slowly removed around the stump, and 60 degrees cut. And after that, additionally, the same lengths were cut to make a wider aperture. You can identify the lumen of the donor artery. Important point. We have to confirm the lumen, both graft and the donor artery and the recipient artery. After that, all preparation done, the trapping of the recipient artery, and we're ready to go. And the recipient artery cut using the 27 gauge needle. the straight arteriotomy was done. Then please take care the complete straight arteriotomy may be good. And both state suture was done, and also there are additionally suture was completed. And the ICG video angiography confirmed the patency of the graft. Next, I launched to the next second anastomosis. This is a frontal M4. Also place the rubber seat under the recipient artery to secure the recipient artery and the temporal occluded. And the second STMC anastomosis, M4 anastomosis, but down. The straight arteriotomy, the complete hemostasis is important to clear bloodless surgical field. And when they're inserting the needle under the highest magnification, important. And after that, the second anastomosis also confirmed the patency by the ICG. After that, other indirect revascularization, temporal muscle and the pericranium and the fascia was covered over the brain, and the bone flap was replaced, and the surface layer of the temporal muscle was reapproximated original position and closed. And the postoperatively there was no event, no adverse effect, and DSA demonstrated both graft or patent. And additionally, one point lesson today, I just want to stress the needle entry point for the recipient artery and the donor artery. The insertion point, entry point for the recipient artery is very close to the cut edge of the vessel. Can you see? Okay. You can see the needle insertion point is very close to the cut edge of the vessel to avoid the adventitious inversion. You can see the tip of the needle, highest magnification. So bring out a little bit, and you can confirm the lumen, and the tip of the needle is inserting the very close to the edge. Very important point. The intraoperative, sometimes we encounter microbleeding, minor bleeding from the trap because of this weak, maybe. In this situation, we should additionally creep up applied to make a bloodless surgical field. And every needle insertion, we should confirm the tip of the needle inserting the appropriate position very close to the cut edge here. This is the appropriate position. And also you can notice I'm confirming the lumen of the recipient artery to avoid the missed stitches. This is the important point. Every needle insertion, I am also confirming the lumen, and the tip of the needle is just close to the cutting edge. For the successful bypass, you should confirm every needle insertion. Tip of needle penetrating the vessel wall very close to the cut edge. Post-op, after that, ICG confirmed the both graft patent. Okay, take home message, create a bloodless surgical field to obtain a clear view of the vessel lumen and the cut edge. Pass the needle as close to the vessel edge as possible to achieve the proper intimal eversion and accurate intima to intima position. Consistent practice is the key to becoming a skilled bypass surgeon. Thank you for your attention. Thank you.
Thank you so much, Kimura Sensei.
You-
Again, very quick tips for us when we are starting the bypass surgery. Any
Thank you.
comments? On? So shall I invite Professor Ellison for your comment?
Professor Kimura, thank you very much. Really great, great surgery, great presentation, and really focused on the technical techniques of microaneurysm, all this. I have one question. If you have, as you're focused on the technical, my question is, how do you provide the hermetic closure of a wound when you put the pericranial flap on the surface of the hemisphere? How do you provide the closure of the wound, and do you prevent CSF leakage
Oh, great.
and the accumulation of CSF? I think it's really practical.
Yes, thank you very much. Good question. So, in the past, I sometimes suffered, of course, even for the small number of cases, but I experienced post-operative CSF correction under the skin flap. But recently, nowadays, I use the Duragen to closing the dura, so surrounding the graft. So after using the Duragen, I never experienced the post-operative CSF correction and after the scalp. Good material for to avoid the CSF leakage, even in the bypass cases using the Duragen. Thank you. But yes,
Thank you.
Thank you.
Thank you very much.
Thank you.
Yeah, Professor Kimura, can I ask a short question? And
Thank you.
I think to you or Professor Kato or Biswa or someone who's doing the bypass surgery, I would like to ask about there is some bypass surgeons talking about the step for the de-air, for the gas, to expel the gas bubbles from the bypass, and the gas bubble. So how do you perform the degas or de-air procedure? That means to expel the gas bubbles from the anastomosis before you release the cam.
Gas? How do you mean gas?
The gas bubbles inside the anastomosis. So how do you minimize the gas bubbles before you unclaim, or any special steps to remove the gas from the after
gas
the
part. Yeah.
Yes.
Oh, okay, I understood. But in the STMC bypass, we have no problem, no concern about the intraoperative in the gas in the vessel. But you please use a saline solution to irrigating the lumen frequently intraoperatively to avoid the gas inside the recipient artery, also in the donor artery. No, we do not experience such kind of problem regarding that gas. Thank you. Flush out, yes. Important. Thank you.
Yes.
Sensei, can I ask a question?
Yeah, please, thank you.
Sensei, especially in case of young children, we face a problem of necrosis of the scalp after the surgery. Bypass is okay, but there is own descent. So is there any special tips used to share with us to avoid necrosis of the scalp?
Scalp, yes, scalp, yeah, important point because maybe in the children case, the scalp is very thin.
Very thin.
Especially, yeah, totally agree with the question. So we need to special care post-operatively the wound coloration and yeah, we have to pay attention to that. But the important point is making a skin incision is not so to considering the feeding nutrition of the scalp, considering the in making a skin incision. The shape is important. Not a straight, not angled skin incision is not good. So like a curvilinear skin incision is good for the patient's skin incision to avoid the scalp complication, I think. But the very important point, we have to care about it, the post-operatively. Thank you.
And last one question. 2 days back, I have done a DSA of a patient of 42 years. She had a watershed infarct on the left side.
Yeah.
So when I did the DSA, patient has Moyamoya disease. On the right side, it's almost Suzuki grade 6 on the right side. There are many transosseous transdural bile supply from the meningeal and also the ST and occipital artery. It's on the right side. But on the left side, no meningeal contribution, just only occipital contribution. And patient had left-sided watershed infarct. Should we go for revascularization of the patient on the left side?
Yeah, maybe I think the symptomatic side is the most first treatment option for the bypass case, which is a symptomatic side, right side or left side, which the patient suffer the
patient has right-sided hemiparesis and the left side in
right
the MRI.
Right side hemiparesis. So that's why the left side is a symptomatic side. Left side is maybe the first treatment option for the case. Thank you.
So if there is extensive bile supply, should we avoid surgery in those cases?
Extensive bile supply.
From the meningeal branch or the scalp artery.
Maybe in such a case, bypass, maybe, yes, this case is 42 years old. And also we have to consider the bypass treatment first, direct bypass. But if you can't do the bypass surgery safely, we just consider the indirect bypass only.
Indirect bypass, okay.
Yeah, only maybe. But yes, even in the small incision, you can harvest about 3 or 4 centimeter STA, maybe mandatory for the bypass case. Not so large craniotomy, just a small craniotomy may be sufficient for the just performed bypass. So if, as possible as you can to choose the bypass direct anastomosis, direct revascularization first for the, especially for the adult case, I think. Yeah, thank you.
Thank you. Thank you.
Good question. Thank you. Thank you.
Thank you so much, Kimura Sensei. I think we all learned so much from you.
Thank you.
So, any comments, final remark from Professor Kato for Kimura Sensei's lectures?
So the phrase Moyamoya is still quite difficult because Japan or maybe Korea or some Asian country has many Moyamoya cases, but I think other country is quite a small number, I think. So maybe they can learn from the expert, I think. So case by case. And also just you can check the CFP, not CFP, cerebral blood flow check, I think. That's very important.
Yeah. Blood flow. Thank you.
Thank you. Thank you so much.
Maybe we want to ask Dr. Lin because Dr. Lin has so many cases in Moyamoya in China. Dr. Lin, you want to say something?
Professor Lin, can you share about your experience? Please unmute yourself.
怎么说？Ben 怎么说？
你的经验总结一下吧，就是你的经的。
那不敢，这位专家在，我怎么总结？因为病我们虽然也做了不少的临床的病例，但是还有很多未知的一些领域，包括这个机制，这个与发病的原因，对我们来讲，我觉得血流动力学的一个评估可能是最难的一个地方。对，我们没有到现在依然没有好的办法可以评估它的一个血流动力学的一个变化和以及我们做完手术以后血流动力学到底往哪个方向去走。
And just a final remark from Professor Lin about the experience of Moyamoya disease. The hardest, he's currently doing some research projects on some the pathophysiologies, say on some of the vessels and also the dolor and about the pathophysiological changes. And but he thinks that the most difficult and unpredictable part is the hemodynamic changes after the before and after the bypass surgery, about the change of the hemodynamic. And yes, and maybe CFD is one of the solution, and maybe other hemodynamic measurements, maybe some of the solutions. Yes, so
Yeah.
thank you so much to the to all the speakers. Before closing, can I have 2 minutes to share about the future events of our ACNS? And just to have a quick share. So the next coming is the next coming one is the ACNS Congress in Mumbai. Oh, sorry. Which will be happening next week, and then we are celebrating the 15th ACNS Congress with the theme of the philosophy, technique, and technology, and analyzing the future of neurosurgery, which will be happening on the next week. And I'm glad that we are meeting very soon physically, and then the next one is the coming one is the Yismin Congress, and in the September 4th to 6th in Shanghai, in the Shanghai Huashan Hospital. We'll have the Yismin Congress 2026, and for the registration, you can click the QR code or go to our ACNS website. And last but not least is our 4th World Congress of Young Neurosurgeons. So we are in the 30th October to the 1st of November, and we have the theme of the innovation in neurosurgery, and we'll have a panel of distinguished speakers coming to Hong Kong, including Professor Kato, Professor Louis Baba, Professor Misra, Professor Toko, for example. And the workshop is now available online for registration, and also please register and please submit your abstract if you're interested to join. And I hope to see you all in physically in the future. And thank you so much for the support for the ACNS, and I hope to meet you all in the future. Thank you so much.
Thank you.
Thank you very much.
Bye-bye.
Yeah.
Thank
So
you.
much.
And thank you, Ben.
See you, Hong Kong.
See you.
Yeah,
Bye.
see you.